Okay, we are back on the record at 12:55 p.m.
Dr. Burks, when you spoke to the nephrologist and told the nephrologist you wanted to order stat hemodialysis for Mr. Allen, did you and the nephrologist also discuss all the other forms of treatment that you were going to implement in Mr. Allen's case?
No, sir. Not necessarily, not that I recall. It may have been in the discussion of, I'm going to do this while you're arranging your dialysis, but I don't recall specifically discussing the acute management that I was performing.
The acute management.
The acute management that I was ordering for Mr. Allen.
Okay. Doctor, there's a note in your discharge summary that Mr. Allen had refused his labs during the morning of March 18th.
Yes, sir.
I don't see any other note in the chart about that refusal. Can you tell me how you learned of that information?
I would have learned of that information that morning because the labs are ordered typically for 4:30 in the morning, and when they're drawn, they result back by 7 or 8 o'clock in the morning. So I would have seen his labs prior to evaluating him that day. And when they had not returned, and especially once he began developing the arrhythmia, that's when it would have been brought to my attention that he had not received, or he had not had allowed the labs to be drawn.
Well, when you arrived at 7 o'clock in the morning, you would have seen from the chart that there had been no 4:30 blood draw, correct?
I would have seen that the labs were not yet resulted, and at times the lab can be backed up, there may be a delay, so I wouldn't have thought that it was particularly abnormal at the time. It can sometimes be it can come back much later than that. It was only after began inquiring to where the lab was that lab had not been drawn.
Did you begin inquiring that around 12 o'clock when you started this to appreciate the bradycardia and then after the EKG?
I'm not sure exactly when I would have began inquiring. I know that I noticed it when I first came in, and that certainly when the issue arose, I would have reiterated that. And he had stat labs drawn at that time.
Okay. So if you had realized that Mr. Allen had not had a blood drawn at 4:30 when you came in at 7 o'clock in the morning, would you have ordered a stat blood draw at that time?
No, if I would have known that he hadn't allowed it to happen, I would have talked with him about that and asked that they come back and draw them.
But
because at that point there was no indication to me that he had a problem.
Okay. So I guess my question is, did the fact that he, if we rely upon the chart, either refused the lab draw at 4:30 or it just didn't happen, did that affect in any way, shape, or form the course of treatment that you recommended for Mr. Allen on the 18th?
That's a very general question. Can you refine it for me?
Yeah. Well, what I'm trying to say is the fact that you didn't have the blood test back at 7 in the morning, did that affect your management of this patient?
Again, I'm trying to understand. If you mean that hypothetically, do you mean hypothetically, if the blood had been drawn and the results were back at 7 o'clock in the morning?
We can go with that question. Sure.
What would have happened then?
Yeah. Mm-hmm.
If the blood had been drawn at 4:30 and I had the results back in the morning, his potassium level would likely have been elevated, although not to the point where it was causing appreciable changes in his EKG. Nonetheless, with the elevated potassium, I would have called the nephrologist at that time to notify them of the lab and encourage that dialysis happens sooner rather than later. And then that would have been up to them as far as when they would schedule it. But typically when people have a more, in that case, he would have a more urgent reason to have dialysis, although not quite fully emergent. He likely would have been dialyzed in the morning hours rather than in the afternoon, possibly before he had developed the arrhythmia, which then would make all of this somewhat not relevant, because then he wouldn't have developed the arrhythmia. It wouldn't have prompted my decision or my need to treat him emergently, and he would have had his dialysis that would have taken care of the hyperkalemia that put him at risk later that day.
Okay. So to understand your testimony, if you would have had the lab results back by 7 o'clock or 8 o'clock on the morning of the 18th, you believed it would have shown an elevated potassium level, but the level would not have been elevated enough at that point to cause the urgent, life-threatening condition with the heart, correct?
Correct.
Then you would have ordered dialysis, and he would have had dialysis sometime in the morning, although not on a stat basis, but you believe he would have had dialysis sometime in the morning, and that would have taken the potassium levels down to the point that he wouldn't have developed this emergent, life-threatening situation at 12:30 in the afternoon.
Objection.
Is that
You can
correct?
answer.
Everything about that's correct, except that it wouldn't have been me ordering it. It would have been me talking to the nephrologist about an order, and we coming to a conclusion together.
Okay. All right. And you weren't aware that his labs hadn't been drawn until around 12 o'clock when the bradycardia started to become evident, and then after the EKG showed the unusual heart rhythms. Would that be a fair statement?
Objection. He's already answered that. Go ahead.
I'd say that I was not aware of the importance of them not having been drawn until he developed an arrhythmia, at which point it became very evident that I needed to have those labs.
Well, when did you first find out that the labs hadn't been drawn at 4:30? If you could tell me.
Objection. Asked and answered. Go ahead.
Well, the first indication would have been they weren't resulted by 8 o'clock. And so between 8 and noon, I would have been aware that they hadn't been performed.
If you had been aware at 8 o'clock in the morning that they hadn't been performed, would you have ordered them on a stat basis in light of this patient's condition?
Objection. You can answer.
I wouldn't have ordered them necessarily on a stat basis. I would have requested that the lab draw come and obtain them so that we can, because I knew that he hadn't been dialyzed in more than 48 hours, and that nephrology, in absence of a more acute reason to dialyze someone, tend to rely on such labs to make the decision on when the person will be dialyzed that day, if they need to be dialyzed that day. And so I would have asked that they come back and have them drawn on a non-urgent basis.
Would you believe that knowing what Mr. Allen's potassium levels was in the morning of the 18th between 8 o'clock and 9 o'clock in the morning would be something important for you to know as his attending doctor?
Objection.
Could you restate the question?
Right. Knowing or being aware of what Mr. Allen's potassium levels were between 8 o'clock and 9 o'clock in the morning on March 18th would be something important for you as his attending doctor to learn, would it not?
Objection.
Yes, it would be important to know. However, it would not, at that time, have warranted a stat or emergent blood draw.
And how long does it take, in your experience, for the lab in the hospital to complete a blood draw and to get the results back?
Once the lab has the blood, it can result in as little as 30 minutes.
And on a stat basis, is it shorter than that?
It takes about that long for the machine to actually process the blood.
So about 30 minutes, whether it's stat or routine?
From the time that the lab receives the blood. A routine lab draw would be having a phlebotomist come and draw the lab from his arm, from a peripheral. In his case, a stat lab draw would have come from his dialysis catheter and would have happened as soon as I said, please draw this from his dialysis catheter,
Okay.
which ultimately is what happened.
That's what happened around 12:30, correct?
Correct.
All right, that's how the stat blood drawn was taken at 12:30.
Correct.
All right, doctor. Can you tell me the conversation did you remember having with Mr. Allen's family members? That would include his wife and any of his children who were at the hospital.
Boy, that's at any given time?
Whatever he can remember.
Well, that's a broad question. I
It is a
object.
broad question, but I'm trying to ask you what you remember.
I object as to how he's going to be able to answer that without being prompted as to a specific date and a specific event. But I'll let him try, but I object.
I'll put it this way. I recall Mr. Allen and his wife pretty well. We spoke, obviously we spoke every day that I was attending for Mr. Allen. We had several discussions not only about his medical care, but also about his life and his goals. They spoke to me about their faith on one occasion. Following the event, I remember seeking Mrs. Allen out to talk with her, because I had those conversations. I felt that we had a relationship that, at least having a more familiar face than the people that she met in the ICU very briefly, would at least give her some comfort in that time. I don't recall where we had that specific conversation. But I spoke with her and I apologized to her for the situation that she was in, and that I felt sorry. That it's very difficult for her to watch her husband go through this. And I guess, is there anything else you'd like to know?
Right. Miss Allen recalls that you apologized for ordering and giving the Caxlate to Mr. Allen, that you had panicked and gave him too much. Do you remember that conversation?
No.
Did
No,
you ever?
I did not apologize for my treatment of Mr. Allen.
Okay.
Again, I was empathizing that anytime someone has an adverse event or takes a turn for the worst, as a physician, you feel for the family, or at least I do, and so that was my apology, and I certainly, the Caxlate was, in my eyes then and now, an absolutely a very important part of the treatment of his arrhythmia.
Doctor, did you explain to Mrs. Allen before her husband went in for the surgery on the 19th that the reason for the surgery is because Kexlate was eating away his bowel, causing ischemic bowel?
No, sir.
Did you give her any explanation why his condition has deteriorated to the point of requiring surgery?
I
I'm sorry.
I gave her many reasons that could have resulted in her husband taking a turn for the worst and needing surgery.
Was one of those reasons that Kexlate may have caused the ischemic bowel that he was suffering from?
One of those reasons was that there had been an association between Kexlate and ischemic bowel, but he had many other conditions that were much more likely to have contributed to the development of that.
Did you explain to her what you believed to be the condition that more likely than not contributed to the ischemic bowel, other than the ingestion of Kexlate? Did you have that in-depth conversation with her?
Objection as to form and foundation of that. You can answer.
No, I never gave her a firm, because at that point we didn't know, and I think at this point we can still say we don't know specifically what one thing may have caused the ischemic bowel. So I would not have spoken in absolute terms and told her that this is the most likely thing that caused it. And nothing that we have so far in the record or otherwise specifies a causative reason for his ischemic bowel.
Doctor, do you intend to render an expert opinion in this case as to what actually caused Mr. Allen's ischemic bowel or not?
I don't understand the question.
Okay. If you take, your lawyer may help you out with this, but normally what I need to know is, for these depositions, is what opinions do you intend to give if this case goes to trial? And I want to know whether or not you're going to get on the stand and your lawyer's going to say, Dr. Burks, do you have an opinion to a reasonable degree of medical probability what caused Mr. Allen to develop the ischemic bowel for which he needs surgery for? Do you intend to give an opinion in that area?
You can answer.
Okay. I would answer to that question that his cause of death and the cause of the ischemic bowel is multifactorial. None of which that I can say one had played a larger role than another. The factors that could play a role would be his end-stage liver disease. He had a history of congestive heart failure, his renal disease or kidney disease, certainly the rapid muscle breakdown he was experiencing, the rhabdomyolysis, and the fact that during the hospitalization he had periods of having low blood pressure. All of these things will decrease the perfusion to the bowel, and it's impossible to really say with any certainty which one of those caused the final deterioration to the point that he required surgery.
So it's fair to say that you cannot render an opinion within a reasonable degree of medical certainty which of the conditions he was suffering from was the approximate cause of his ischemic bowel. Would that be fair?
I object as to form. You mean which one individually? He's already testified a combination, multifactorial.
Which one was the approximate cause of his ischemic bowel? You cannot pinpoint out which one, correct?
A single one is what you're saying. I object as to the form of the question.
Correct. I couldn't say that this one thing pushed him over the edge so that he developed critical bowel ischemia.
By the same token, you cannot affirmatively rule out that the ingestion of Kexlate was not a cause of the ischemic valve. Would that be correct?
Objection as to form.
I'd say that there's no certainty there at all.
Okay. Doctor, do you intend to give any other expert opinions at trial?
Well, that's, if you let me assist with that, because that's going to be my decision. He's going to certainly testify about his care, and that his care met with the accepted standards of care. He'll testify on his own behalf.
Is he going to go into standard of care opinions?
He's going to offer a standard of care opinion that, as we said in his answers to interrogatories, the diagnosis of hyperkalemia was appropriate, and his management of that, including the insulin, the glucose, the sodium chloride, the albuterol, the Kayexalate, and ordering an urgent nephrology consult, all met with accepted standards. He's going to say that that was all within accepted standards of care.
Doctor, what is your understanding or definition of the standard of care that applies to doctors such as yourself for treating patients such as Mr. Allen?
Well, that would be what any reasonably competent physician would do in a similar situation.
Okay. Do you believe that it is a standard of care in this case to order Kayexalate for Mr. Allen when dialysis is readily available?
Given the emergency of the situation and the unknown of how long before dialysis could begin and how long it would take before dialysis would effectively lower the potassium, yes, I would say it would be.
But I think your testimony was it didn't matter whether dialysis was ready in 10 minutes after you talked to the nephrologist, you would still order the Kayexalate and all of the other medications for Mr. Allen, correct?
Right, but we were speaking in terms of this case.
Yeah.
So that was a hypothetical. And so hypothetically, I would still say yes, I would give Kayexalate in that case.
Okay.
In this specific case, when the only insurance I had was a range of time, then that is, for me, even more justification for the use of that medication.
All right. I may have not remembered this correctly, but I don't remember you telling me what is the range of time that the nephrologist told you they could begin dialysis for Mr. Allen.
Correct. He said that he would be, that they would order it and that it was on the way or en route. And that statement was vague enough for me to, and he couldn't specify how long it would take to get there because, again, he would have to arrange the nurse, the machine, if the machine had to be freed up, all of these things that I wouldn't expect him to know off the top of his head, and therefore he wouldn't be able to give me a firm answer.
But it's my understanding that whether the firm answer was 30 minutes, a half hour, or 10 minutes, you would still have went forward with the same protocols that you followed in this case, correct?
Objection as to form and foundation.
I guess I'm not understanding maybe the relevance of the question.
Well, instead of the relevance, could you just answer the question instead of trying to understand the relevance why I'm asking it?
Well, I object. I mean, he has to understand the question.
Do you not understand my question?
I understand. No, could you re-ask the question?
Okay. If your understanding was the dialysis could have begun within 10 minutes, 15 minutes, half hour, hour and a half from the time you talked to the nephrologist, would that have changed the protocols that you followed in this case for the treatment of Mr. Allen?
Objection. Form and foundation.
Yeah, and as I had said before, no, it would not have changed it.
Okay.
But the reason, I think the confusion is the reason that I'm adding the further justification of the unknown of how long. Because when you're in the situation of watching someone with a potentially life-threatening arrhythmia that could deteriorate at any time, having an unknown of whether it's going to be 10 minutes or 2 hours, which it ultimately ended up being, to sit idly by and not give another medication that potentially could also effectively lower the potassium and save his life, then certainly that just added more reason for me to provide that medication.
Does your handwritten note at 13:45, does that indicate the time that you spoke to the nephrologist? And you can look at that, pull that up.
That's page 1559 of our records. Excuse me.
No, it doesn't give a specific time.
It doesn't have the time for your note?
It has the time for my note, which was 13:45.
Okay.
But it doesn't. I thought the question was, does it have the time which I spoke with the nephrologist? And that is not specified in my note.
Okay. There's an... Do you recall, other than the time of 13:45, when you said renal called for urgent hemodialysis and hemodialysis en route, do you have any idea, going back in time, when that conversation occurred?
That conversation would have occurred at approximately the same time as the other orders that I placed, the other urgent orders that I placed, including the calcium gluconate, the albuterol, the Kayexalate, the insulin. All of those would have happened in a rapid succession. So my best estimate would be between 12 o'clock and 1 p.m.
Doctor, do you believe that the standards of medical care are developed primarily for patient safety?
Objection as to this is the reptilian brain
But
theory.
wait a minute, if you're going to do a speaking objection, the witness has to...
I'm going to instruct him not to answer that question. But I don't see how that's relevant to this case.
Doctor, do you believe that standards of care, that physicians develop those, and partly for patient safety?
Objection, don't answer that question.
Doctor, why do you believe standards of care are developed by doctors?
Objection, don't answer.
Doctors, where did you learn standards of care from?
Objection, don't answer.
Doctor, how did you learn what the standard of care was in this case?
Objection, don't answer.
Doctor, what did the standard of care require you to do in this case for Mr. Allen?
Objection as to the breadth and scope of that. I instruct him not to answer, says it's so vague and overbroad in general.
Doctor, on March 18th, when you saw Dr. Allen, what did the standards
Mr.
of care...
Allen. Mr. Allen, you
Yeah,
said
Mr.
doctor.
Allen. I'm sorry.
All right.
I'll rephrase the question. On March 18th, when you came in for your 7 o'clock a.m. to 7 o'clock p.m. shift, what did the standards of care require for you for that day for your treatment of Mr. Allen?
Objection as to the breadth of that, but that's a little bit more focused. I'll let him answer that question.
The standards of care are broad, as we've kind of established, generalizations. And so to say that what is the standard of care that directly applied to one case, it's got to be taken on a case-by-case basis. But in the standard of care for Mr. Allen, and I think any other reasonably competent physician faced with an unstable heart rhythm that could deteriorate at any moment, would dictate that they would give and do everything they had within their power to prevent that. And in this case, for the hyperkalemia, the rapid rise in hyperkalemia, that standard of care would be to provide a membrane stabilizing agent such as calcium. It would be to rapidly push the potassium into the cells using albuterol, insulin, glucose, sodium bicarbonate, and then finally to get the extra calcium out of the body, and that would involve doing one or all three of the things available to you, and that would be giving K-exolate to get it to have the patient excrete that through the bowels, initiate the hemodialysis, or try to get the kidneys to excrete the sodium by the use of medication called furosemide. In Mr. Allen's case, the furosemide wasn't an option because his kidneys weren't working. It would have done nothing. Therefore, I did the two things that I had in my power, and I think any other physician would have done those same two things, and that would have been to give the K-exolate while awaiting urgent dialysis. Is that
No, wait for the next
okay?
question.
Okay. Does a reasonable and prudent doctor have to explain to the patient the risks of the recommended treatment?
Objection as to the scope of that question. You can answer.
I'd say if the risk is of a material risk, to define that would be a risk that happens often and severe enough as to change the patient's desires for that medication, depending on the alternative. So it would be a risk that would push the risk-benefit ratio, so to speak, or analysis to the point that giving the medication it would be prohibitive, meaning that the medication would be more likely to harm the patient than the condition for which it was treating.
So the answer is you believe that the standard of care requires a reasonable and prudent physician to advise the patient of the material risks associated with the proposed treatment plan.
Objection as to form. Foundation, you can answer.
Yes.
Okay. I wanted to talk to you about amended responses to the plaintiff's request for admissions of fact. Oh, one other question. Was Mr. Allen given the option to delay the admission of KX late until after he had hemodialysis on March 18, 2013?
All patients have the right to refuse or delay the administration of their medications. And this was a right that he had exercised earlier in his admission by not taking a medication called rifaximin, which is used to treat confusion related to end-stage liver disease or hepatic encephalopathy.
Did you give Mr. Allen specifically the option to delay the KX-late until after he went through hemodialysis in this case?
Objection as to form and foundation. You can answer.
No, I did not specifically say you can or you cannot receive this medication.
Okay. Other than the one note in your discharge summary where Mr. Allen refused the blood draw at 4 o'clock, 4:30 in the morning on March 18th, are you aware of any other instance where Mr. Allen refused any of your recommendations for his treatment?
Yes.
Okay, tell me those.
Multiple occasions he did not take the rifaximin that I had just mentioned.
Do you believe that that had any contributing effect on the ultimate ischemic bowel that he developed?
I doubt it.
Okay. Anything else that you can think of, doctor?
Those are the only two that come to mind.
Do you know Dr. Morietti?
No, sir.
Were you aware if there were any other policies in place at the hospital that recommended or suggested that physicians not use KX-late for the treatment of acute hyperkalemia when dialysis was readily available?
Could you repeat the...
Sure. Were you aware when you treated Mr. Allen whether there was a policy in effect at University of Maryland Hospital that suggested or cautioned doctors from administering KX-late to treat acute hyperkalemia when dialysis was readily available?
No, sir, I was not aware of any policies.
I'm almost done. I'll need just about a 5-minute break to go through.
All right.
If you had any follow-up questions you want to ask him in the interim or not, I didn't know. Just
I'm not
to save
going to
time.
ask any
Okay.
as of this moment.
All right, I'll just need just a couple minutes to go through.
So we can go off the record so we don't run blank tape.
We're going off the record at 1:34 p.m. We are back on the record at 1:40 p.m.
Doctor, at the time you treated Mr. Allen, were you aware of the position and opinions that Dr. Morietti expressed during his MCRAT podcast almost 2 years before?
No, sir.
Would it be fair to say that you did not diagnose Mr. Allen with ischemic bowel before you ordered the KX-late for him?
That's fair.
And would you fair to say that Mr. Allen did not have ischemic bowel before he ingested the KX-late?
I can't say that.
Is it you just unable to reach that opinion?
I don't understand what you mean by that.
Okay. Are you denying it, or you just don't know?
I don't think that we can know whether he was suffering from that prior to the time or not.
Well, I don't know who you mean by we. I'm just going to concentrate on what you know. Did you didn't render a diagnosis that Mr. Allen had ischemic bowel before you ordered Kexley, correct?
Correct.
If you had rendered a diagnosis that Mr. Allen had ischemic bowel before he ordered the Kexley, would that be part of your notes in your chart?
Yes.
Okay. Now, were you aware of any FDA warning that applied to the drug Kexley before you ordered Kexley for Mr. Allen?
No.
There's two requests for admissions of fact that I want to draw your attention to. It's on your amended responses to plaintiff's second request for admissions of fact, and it's request number 22. It says on March 18, 2013, Dr. Clarissa Jones Diamantidis was aware Dennis Allen was going to be administered Kexley before the hemodialysis treatment she ordered for Dennis Allen on March 18, 2013 was to begin. And you denied that. And the next question I asked was, on March 18, 2013, Dr. Clarissa Jones Diamantidis was unaware Dennis Allen was going to be administered Kexley before the hemodialysis treatment she ordered for Dennis Allen on March 18, 2013 was to begin. And you also denied that. I asked the questions, one positive and one negative, and they're both denials, which means one of them has to be inaccurate. And I'll just show them to you and ask you if you can tell me which was inaccurate.
So we denied that because of the premise of the question was wrong. You reshaped the question. If you look at the records, Dr. Sana ordered the hemodialysis. That's why we denied that, because the premise was wrong. So if you take out the part that she ordered it, I'll let him answer the question.
Okay.
As to which one is accurate.
Okay.
You understand?
Thank you. I do now.
All right.
All right. So let me re-ask the questions. Do you acknowledge or admit that on March 18, 2013, Dr. Santa was aware Dennis Allen was going to be administered Kexley before the hemodialysis treatment he ordered for Dennis Allen on March 18, 2013 was to begin?
So the question is, was Dr. Sena aware that Mr. Allen was going to receive Kexley prior to ordering dialysis for him that day?
Prior to the beginning of the dialysis treatment that he ordered, right, was to begin.
I would, again, this kind of goes back to the conversation, recalling the conversation between Dr. Santa and I, and whether I specifically mentioned that he would be receiving Kexley or not, and I don't recall. I would have told him I'm treating him for acute hyperkalemia.
Right. So there's no way to know whether he knew it or not, because you don't know whether or not that was a specific part of your conversation with him.
Right. If we're being very specific about, if I specifically told him and said the words, I'm giving him Kexley, I'm giving Mr. Allen Kexley, I can't answer that. I don't know.
Okay. That's all the questions I have.
I have no questions. We would like to read and sign.
All right, this is deposition of Alan Cole Burks. The in time is 13:46. We're going off the record.